Thank you very much, Steve. I'm honored to be here. Although the plug about the Iron Man, I'm surprised I'm still not there trying to finish. It took me that long, and they ran out of water halfway through in an event that's roughly around the equator. But in any case, I'm delighted to be here. I think it's a tribute to the organizers that they'd be open-minded enough to have me come and talk about some of these issues. I'm a neuropathologist, and I've studied neurodegenerative diseases quite a lot over the years. I started out studying prion diseases and Alzheimer, and I at the same time I was always clinically oriented, and so I do a lot of work with neurosurgeons and consulting on neurosurgical cases. Just about every day I'm going into the operating room and looking at specimens and giving diagnoses. And so I'm not just in a research setting, I'm in a clinical setting, and I'm sort of keenly aware or keenly sensitive to issues that are diagnostically important or diagnostically meaningful. So if you add that to neurodegenerative diseases and this new entity of chronic traumatic encephalopathy, I think some of my thoughts on the issue are worth noting. I have no conflicts of interest. This is a definition of CTE put out by the Boston University website, and it says, the usual. It's a progressive degenerative disease with a history of repetitive brain trauma. Everyone's heard that. But I just focus on the last part, including the buildup of an abnormal protein called tau. So let me just focus on tau a little bit. The neuropathologists are kind of famous for snowing clinicians with neuropathology, and so I think I'm trying to give you some insight into the lion's den of neuropathology here, so you can't be fooled later on. So this is what I would call the preeminent tauopathy, which is Alzheimer's disease. So where did tau come from? Around the turn of the 20th century, Alice Alzheimer was following a woman named Augusta Dieter. She had a progressive neurodegenerative or progressive cognitive decline, psychiatric signs. I don't know her concussion history, but she was examined by Alzheimer several years later, and he used this lately available technique called Bielszowski silver impregnation, and he found these lesions called neurofibrillary tangles. And so it established an entity. So that's basically what a neurodegenerative disease is. It's a clinical disease process, in this case, progressive cognitive decline, and then some pathological substrate at autopsy, in this case, a neurofibrillary tangle, and another lesion I'm not going to talk about in any detail, which is a senile plaque. And so at the time, investigators were fairly circumspect about what that meant. Alzheimer's contemporaries just said it was there, evidence of something going on, but they really didn't understand it. It was really not until the mid-1980s when scientists were purifying this material and cloned it basically and identified the major protein constituent that we really started drawing conclusions about the significance of these lesions. But I would just emphasize that the reason why the lesion is important is simply based on the fact that we can see it. If you can see it, you can correlate it, and now we can purify it, and we can identify a protein, and then we can, if you want, with newer techniques, you can take that protein, you can insert it in a cell, you can put it in an experimental animal, you can start treatment paradigms, and you sort of have soup to nuts translational neurobiology. But if you back up and ask yourself what this lesion actually means, is it cause or effect? I think that's an open question, but the investigators kind of presume, and it's actually in recent years, that these proteins are causes of the disease, when in actual fact they're more in line, in my opinion, with effect of disease. But anyway, that's the neurofibrillary tangle. It's made up of this protein called tau. Tau is chromosome 17. It's a microtubule-associated protein, so basically every nucleated cell in the body makes tau. It becomes phosphorylated during development, and certain times it becomes phosphorylated in disease processes, and it's an enormously complex process. But we kind of use it as an empirical marker for disease. So in neurodegenerative diseases such as Alzheimer's, as was mentioned earlier, progressive supranuclear palsy, and now this new entity, CTE, this tau protein accumulates in a certain distribution, and we can identify it with an immunohistochemical technique. And once we can identify it, then again, we can correlate it and draw conclusions about what it means. But again, it's fairly complex. So why is this a tauopathy, or what is the evidence that these head trauma injuries produce increased tau protein? Probably one of the hallmark studies was this study by Corsellis and colleagues in boxers. He reviewed 15 boxers. This is from the early part of the 20th century, and they basically found increased numbers of these neurofibrillary tangles that were kind of out of proportion to the plaque pathology. And so that sort of codified the presence of neurofibrillary tangles in this disease that we now call dementia pugilistica. Although it's important to note, even in that study, that the cases were heterogeneous. These were boxers who had enormous boxing exposure, 600, 700, 800 fights. They had a lot of comorbidities, vascular disease. A number of them were alcoholics, and not just your garden variety alcoholic that you see on college campuses, but big time drinkers. One had neurosyphilis, one had a cavernous malformation that bled. A lot had vascular disease. So even in the landmark study of dementia pugilistica, it's really a set of cases that is littered with comorbidities, and what they found was increased neurofibrillary tangles, and everybody sort of buys that. But this newer finding, I'm not going to talk about in detail about this perivascular tau and tau in the depth of the sulcus was really not part of those cases, so far as anybody knows. But anyway, that was one study that raised this chronic head trauma as a, quote, tauopathy. And in this case from 2005, that was published in Neurosurgery. And again, I bring this up every time I get a chance to talk about this, because I think it's worth noting. So this is the index case of chronic traumatic encephalopathy in a football player that was published in 2005. And the only objective data I have to go by in terms of what's going on in that brain neuropathologically is what's pictured here. And I can tell you, and I think this is objective. I think if you showed this material to anyone, any neuropathologist, they would say there's nothing there. You see a couple of diffuse plaques with amyloid beta, a few neuropil threads here and there. I mean, it's actually a very healthy-looking 50-year-old brain. So that already is of some concern, because this is, again, is this chronic traumatic encephalopathy, was this whole discussion, and it initiated by a case that was a normal, healthy 50-year-old brain. And perhaps we could be encouraged by this, because this was an individual who had an enormous exposure to head impacts, and yet at age 50 he had essentially no pathology. So to me, that's somewhat encouraging. And then a few years later, McKee and colleagues described a number of athletes, and they sort of solidified this entity of chronic traumatic encephalopathy as being a tauopathy, increased production of phosphorylated tau. And one thing I just point out, you see that slide to the right there. Those are 50 micron thick sections stained with an antibody, a tau called AT8. It's a very robust antibody, and these are very thick sections, and nobody really does these for diagnostic purposes. It's purely for illustration purposes. And it's a very sensitive way of detecting tau protein. So if you want to detect tau anywhere, this is a technique to do it. But again, I just emphasize that most labs don't do this. It's too labor intensive. But the data is used to illustrate pathology and to kind of highlight findings and almost in a way to sell your findings by showing these nice whole mount brain sections. One thing that I think is important and worth noting is that the human cases of these head injury associated tauopathies are case reports. They're either case reports or they're collections of case reports. And in terms of their place in the hierarchy of evidence-based medicine, they're quite low. And yet this is really driving the thinking in this arena. And at the same time, if you look at some systematic reviews, those, for example, a paper by Gardner a couple of years ago in the British Journal of Sports Medicine, very good review, and he found that maybe 25% of the cases of CTE were pathology negative, 25% of the patients were asymptomatic. Many of the cases had comorbidities. He sort of cast doubt on the entity overall. That's a much higher quality study in terms of the quality of evidence. Now, that's not to say they're not good studies and they're not important studies. It's just that the nature of the studies do not lend themselves to discerning cause and effect. They're really more used for establishing hypotheses and identifying areas in need of study, but they really don't answer any questions. But I think it's pretty clear, though, that these studies are really driving the thinking in this whole arena. And if you have, for example, if you ask yourself, is there a correlation between concussion and chronic traumatic encephalopathy, or this brain change? That question has never been addressed. So we don't know, because the null hypothesis that states that there is no relationship between measured phenomena, we have not addressed the null hypothesis in this disease. So the CTE, as I understand it, is really more of a hypothesis or a concept than an actual reality in vivo in human beings. It's important also to note that phosphorylated tau is a substance that accumulates in everybody as a function of age to some extent. And this is from a study by Brack and colleagues who actually used similar histochemical techniques to the McKee studies. And so basically, if anyone in this room is 20 years or older, you have some phosphorylated tau in your brain. And so it's not a matter of presence or absence of phosphorylated tau, it's a matter of how much and where it is. So when we hear terms like CTE is an age-related, or is a progressive tauopathy, which sounds very prepossessing and frightening, we could say that life on planet Earth is a progressive tauopathy. So that's something to keep in mind. We're not talking about presence or absence of this protein by any stretch. Everybody has it. We're just talking about some subtle differences in terms of distribution within the brain. So there's a neurosurgery case on the right there showing, again, in my opinion, nothing. Is a healthy brain. And I think, again, if you showed this to just about any neuropathologist, they would agree to it. On the left is another football player, an NFL offensive lineman that happened to come through our brain bank, and I've shown this before. I did a large number of immunostains for tau and found nothing for the most part, except for one small collection of tau off in the medial temporal lobe there, which again can happen in anybody. Anybody in this room could have this pathology. And if you blow it up, it looks like, wow, there's some lesions there. There's some inclusions, there's some neuropil threads, there's some neurofibrillary tangles. There must be a chronic degenerative brain disease, but in actual fact, it's just a normal human aging. And so in my own series of NFL athletes, 0% have CTE, but this is N equals 1. Or if I include the one on the right, which I think I can, N equals 2. But at any rate, again, I'm sensitive to what's diagnostically meaningful and what isn't. And so if for example, if you looked in a blinded way at either of those cases, didn't know anything about the case, you would have no clue what their concussion history was. You'd have no clue what their neurological status or psychiatric history was. They just look like normal brains, and yet you could make a case for them having some disease if you misinterpret the data. Now here's another case, this recent case that came into our brain bank. This is a 50-year-old guy, and if it came in as a control, And so we get a lot of controls in our brain bank. I see all of them. I see large numbers of brains of individuals with various psychiatric disorders, which pathologically speaking are also controls. But I happen to get a history that this individual was a boxer. And I said, oh, it's a boxer. So I spent some of the department's money, and I got a bunch of tau immunostains without telling them in advance. And lo and behold, I found some increased tau in the depth of the sulci. As you can see there in the upper left, there's some perivascular tau, there's some tau in astrocytes, there's some tau in the superficial lamina of the cerebral cortex. All these things are buzzwords for chronic traumatic encephalopathy. So this could very well fit into any series of chronic traumatic encephalopathy. The only problem was the guy was completely normal. He died of cardiovascular disease and was otherwise quite healthy. And the wife was interviewed, normal, healthy, productive, good father, no psychiatric disturbances, no neurological disturbances. In fact, avoided going to the doctor. And so what do we do with this? So here's a case where pathologically would fit with quote-unquote chronic traumatic encephalopathy, but yet he lived out his lifespan without any neurological signs. And so can we define somebody as having a disease on that basis? I think that's an open question. I mean, we see at autopsy, you can see people living in their 80s and 90s. They have various findings, vascular findings and so forth, and atherosclerotic disease and have no strokes. Do they have a disease, or do they just have an age-related finding that's just kind of a decoration in your brain as you get older? That's an open question. So again, the idea of autopsy being a gold standard for these clinical diseases is overrated, in my opinion. And this is a complex table. I wouldn't bother memorizing it. In fact, I would avoid memorizing it at all costs because these things will change. But we go through this very convoluted process to assess Alzheimer brains. We look at amyloid, that's where the A is with the amyloid beta stain. Then we do a Brock staging, which is a different protein, tau protein, neurofibrillary stage, and then we do a CIRAD plaque score, and then we give those semi-quantitative numbers, 1, 2, and 3, and then we come up with a Alzheimer's disease neuropathologic change, and say it's A3, B3, C3, and then if you plug that into a table and get your likelihood that this person was demented during life, you can get various levels of likelihood of dementia. But if you'll notice there that it's only the end-stage pathology where we're most certain that the person was demented during life. And I would argue we're only certain that that patient was demented during life when the pathology is the most end stage. Anything less than that, and we don't know. In fact, in the BRAC original study, people could have BRAC 3 or 4 pathology, and many of those patients were cognitively intact. So you can have a tremendous tau burden, a tremendous amyloid burden, and still be cognitively intact. So something to keep in mind when we're looking at brains and seeing little collections of phosphorylated tau and correlating those with clinical signs, there is an issue of overinterpretation there, in my opinion. So as pathologists, we struggle to be able to correlate these protein accumulations with neurological signs, even as simple as cognition, presence or absence of dementia. In a person in their 80s, looking at a brain and trying to decide whether someone had Alzheimer's disease or not is almost a pointless exercise because we can't tell. So in signs as straightforward as cognition, we have a very difficult time. So when I hear about cases of suicide and correlating suicide with a chronic degenerative brain disease, that's when I just kind of check out of the discussion. It's difficult to describe in strong enough terms how ridiculous that is. That we could relate a complex behavioral condition like suicide or explosive anger or impulse control problems with an accumulation of protein in an autopsy. But yet that idea is out there, and it comes out again and again. And since about 2010, heightened suicidality is regarded one of the core clinical features of chronic and traumatic encephalopathy. And again, it's just psychiatric signs are so far out of reach for neuropathology. I just don't understand why they get into it. And I just as an aside here, so I sit in every week on these neuro-oncology conferences where we see 10 or 15 different brain tumors that all have all sorts of very challenging things going on in their brain. And like this one here, this somebody had this very strange protein immunoglobulin accumulation, basically taking over his brain. He was neurologically normal and had all this stuff going on. And we see other lesions in various areas, frontal, temporal lobes. The discussion never revolves around, does this person have impulse control problems? Is this person going to commit suicide? So again, psychiatric illnesses, again, in my opinion, are biochemical, they're functional, they're not structural. So we're kind of conflating two things, structural pathology with functional changes. We just can't do that. So when I see something like this is one of the CTE cases from the Boston University website. 82-year-old guy. How do I interpret this? So this is an immunostain, very thick, and the brown equals tau. In this particular slide, you'll see there in the medial temporal lobe, there's a lot of brown, so it looks bad. But in an 82-year-old, that's not unexpected at all, right? But if you look at where the abnormality is in this case, is those little dots up there in the frontal lobe there. Those are the abnormalities that differ from controls according to the studies. And so relating these little dots to complex functional psychiatric disturbances, again, is a little bit much for me, and I don't think it should be done. I think, and I was talking to Dr. Randolph last night. The most debilitating psychiatric disorder, which is schizophrenia, has no pathological substrate. So people can be profoundly disturbed, profoundly altered, and very sick, and have no pathology whatsoever. That's commonplace in psychiatry. And this is, again, I see a lot of control brains in individuals who commit suicide, and obviously the pathological substrate for suicide is a normal brain. But again, suicide requires neurotransmission, requires action potentials, requires in vivo physiology in order to exist. And I don't think it's a stretch to say that there is no neurotransmission going on in this brain. So I think everybody sort of understands that, but every couple of months I see suicide linked to this, not just concussion. I mean, that's one thing, and that can be determined, or it can be examined epidemiologically, but they're linking it to this tauopathy, which to me is a problem. And this study was alluded to by Dr. Randolph. I thought it was kind of interesting in terms of neuropath psychiatric correlations. That in this large study, the NFL athletes were at a decreased risk of suicide compared to control populations. Something about 40% of the rate of control populations was the suicide risk. And the other thing I'd mention, this particular study, some of these, and I just say this as a pathologist. I don't know if I've heard any specific criticisms of this effect, but in terms of, this was a study done on death certificates, and in death certificates you look at cause and manner of death. Cause of death is kind of what pathophysiologic derangement produced it. Manner of death is the circumstances, homicide, suicide, natural, etc. But I can tell you that in terms of cause of death and death certificates, there are enormously high incidence of errors in death certificates when it comes to cause of death. Now, manner of death, it's a little bit more clear. So if somebody says, suicide is a certain rate, that's pretty reliable. If somebody says cause of death is Alzheimer's disease, that could mean just about anything. But anyway, and this is just kind of tongue-in-cheek, but keep in mind that if those physicians are counseling athletes on a heightened risk of suicide because of their concussion exposure, those physicians counseling them are actually at about 4 times the risk of the athletes themselves in terms of what the real risk is. So physicians probably have to heal thyself to an extent before we start getting into suicide. But again, I take myself out of that discussion. Suicide is as was mentioned, a very profound, very terrible illness, and it has, in my opinion, it needs to be separated from this proteinopathy thing because that confuses the issue. It should be dealt with from a clinical standpoint, and studied from a clinical standpoint, and not be confused by the proteinopathy. This is just again a sort of flow diagram of the paradigm that exists out there, and for chronic traumatic encephalopathy. And the only thing, and I'll speed this up, but it's a very hypothetical paradigm, but it's largely accepted. And if you don't accept it, then you're kind of a denier out there, and that kind of interferes with the dialogue. It's unfortunate because if you say just show me the evidence, you'd be kind of labeled a denier, and it's not a very civil discussion at that point. But there are a few things that I would deny. I'm an unabashed denier. CTE is a well-defined entity. I don't think it is clinically. I don't think it is pathologically. I don't think the rate of progression or whether or not whatever it is progresses is defined at all. I certainly deny that we have adequately studied control groups. I certainly deny that neuropathology can predict psychiatric signs. It cannot, so we shouldn't be talking about that. And neuropathologists, we need to stay in our lane and talk about neuropathology and leave the concussion to the experts. So those are, and this little factoid here, so I can't see this very well, but there's some Europeans studying jockeys quite closely, and it said that the jockeys have something like 500 times the increased concussion risk compared to NFL athletes per hour of sporting exposure. So a little factoid there. And apparently they don't have much in the way of neuropsychological abnormalities, but a very high concussion rate. Some questions worth exploring. Again, control groups. I think it's very encouraging to be at this meeting and hear what's being done because you're really doing it the right way. You are studying concussion in a go-forward, prospective, evidence-based fashion. I think that's exactly what needs to be done, and that's ongoing. So it's very encouraging. And I don't want to go too far into this, but there's unintended consequences that I as a private citizen worry about. Lack of athletic participation. Telling a group of thousands of athletes that they might have this disease. I wonder how many people in this room are worried that they have a progressive degenerative brain disease based on what you read in the media. And I also worry about the impact on people who are already mentally ill, as was discussed. And I just, that paper over there, it talked about the mad cow epidemic and how media exposure led to more cases of mad cow disease in a neurotic and factitious fashion than were actual number of cases. So patients were coming into their neurologist saying, I have mad cow disease. That didn't happen simply because of all the media exposure. I think we have a similar phenomenon in CTE, probably, but others over there can comment on that better than me. And every once in a while, I'm just, as a neuropathologist, I don't have to deal with functional disturbances, but then I'm just sitting there minding my own business, and I see something like this. This came into our brain bank. This is a young man, suffered helmet-to-helmet injury, and apparently returned to normal, and next of kin said he returned to baseline, but he was very upset that he was not allowed to play football at his school and hung himself. So again, we're certainly not saying anything in terms of what caused this. This is a very complex behavioral issue, but I think that we have to be very rigorous and very objective about the data and not raise issues that don't necessarily exist. And I'm not going to get into this, but anyway, that's all I have, and I'll be around for questions later on. Thank you very much.